Hello everyone. I'm just going to give it a few seconds before we get started, as I can still see people are joining us. So we'll just wait for everybody to join. Okay, I think that's everybody. Okay, I'm going to get going. Hello and welcome to today's webinar, Diameter Matters, the Voicing Benefits of the Provox Vega. My name is Kelly Jackson-Waite. I'm the Global Laryngectomy Clinical Lead at Atos Medical. Our presenter today is Claire Rodd, who's the head of Atos Clinical Education in the UK. Claire joined Atos back in December 2022. She's a speech and language therapist by background with 20 years experience working within the NHS and specifically with laryngectomy since 2008. We're also lucky to be joined by Richard Falkenberg today. Richard is the Director of Innovation and Research at Atos Medical and is based at our design manufacturing site in Hörby in the south of Sweden. He has a background in mechanical engineering, and Richard started at Atos in 1998. Some of his first design projects included the free hands device, the active valve, the extra seal, and of course the Provox Vega voice prosthesis. This presentation will be followed by a question and answer session with both Claire and Richard. If you'd like to ask a question at any point during the presentation, please use the Q&A and we will try to answer as many questions as we can at the end. We've pre-recorded the presentation as it will be shown multiple times, but both Claire and Richard will be live at the end to answer your questions. Just a few formalities to cover before we get started. Please be aware that by providing this virtual forum, Atos Medical is not providing specific medical advice. The answers provided during the Q&A are not specific guidelines or endorsements. Before we get started, we have an interactive poll just to find out a little bit more about your clinical practice. So I'm just going to launch the poll. If you kindly just fill it in. Okay, so we're just having a look. Mostly speech therapists listening in tonight. A few nurses. I'll present the results in a minute once everybody's completed it. Okay. Okay, so predominantly it's speech and language therapists with us tonight, speech and language pathologists, 94%. We have a few nurses and some doctors. Looking at diameter of what people use, it seems to be an even split with 46% using a 16 or a 17 French, 41% using a 20 French and 13% using a 22.5. Okay. So I'm now going to move on to the presentation and share with you the presentation from Claire and Richard. So just bear with me while I share my screen with you.
Hi everyone and welcome to today's webinar. Well, we'll be exploring the Provox Vega voice prosthesis and how Vega can create voice benefits and superior voice quality for patients using tracheoesophageal voice following a total laryngectomy. So within the session, we're going to talk about the benefits of tracheoesophageal speech following total laryngectomy, We're going to have a look at voice prosthesis selection, type of voice prosthesis, and the diameter of that voice prosthesis. I'm delighted that we'll also be joined by Richard Falkenberg, who's the Head of Products and Innovation and also Research Director at Atos Medical. Then we're going to have a look at the clinical evidence on voice prosthesis selection and finishing up by putting that evidence into practice with some patient scenarios. Once the presentation is finished, Richard and I will be available live for a question and answer session where you'll be able to ask Richard all things research and development on Vega, as well as any clinical questions that you may have. So nowadays, it's widely accepted that tracheoesophageal speech is the gold standard in voice rehabilitation following total laryngectomy when comparing it to other voicing methods. Tracheoesophageal voice enables patients to achieve a more natural and a more fluent voice. Clinical evidence demonstrates that tracheoesophageal voice has a high rate of success, as well as high voice-related quality of life. For example, Roger Morcabell and his team in 2011 demonstrated that tracheoesophageal speakers had the highest voice-related quality of life compared to electrolarynx users and esophageal voice speakers. Choan and his team in 2005 compared the success rates of tracheoesophageal speakers with esophageal speakers and found higher success rates in the tracheoesophageal speakers. If we summarise all of the evidence that's out there onto a chart, we can see that electrolarynx users and tracheoesophageal speakers both have high success rates, but the tracheoesophageal speakers also have a higher voice quality. So if we look at some of the evidence in a little bit more detail, first of all, thinking about success rate, here we can see a number of additional studies looking at tracheoesophageal voice success rate from 1990 up until 2021, and with a range of 75.8 to 95% success. Just to let you know that all of these references will be at the end of this presentation, and we can send you out the list if you would like to look at any more of the evidence presented in more detail. So let's think now about voice quality. And we know that other voice rehabilitation methods, such as the electrolarynx, have a high success rate, but let's think about the quality of that voice. So Elizabeth Ipe and her team in 2019 carried out a review of patients at their regional cancer centre in India and found that the voice quality of tracheoesophageal speech was consistently higher in quality compared to other voicing methods. Klaas van Sluis and her team from Amsterdam carried out a systematic review of voice outcomes following total laryngectomy in 2018, and they found significantly better outcomes for fundamental frequency, maximum phonation time, and vocal intensity in the tracheoesophageal speech group compared to electrolarynx users. Tracheoesophageal speech was reported as the most pleasant and comprehensible. However, for the patient-reported outcomes in her systematic review, they all reported a degree of voice handicap, but none of the speech rehabilitation groups reported evidently better outcomes than the others. But Klaas did note a number of design flaws in the research in this area to date, such as small sample size, potential bias towards more favourable speakers. So it's definitely an area that would benefit from some further research. If we turn our attention now to the impact on quality of life, additional studies have established that the use of voice prosthesis after laryngectomy significantly increases a patient's quality of life and their self-esteem and decreases depression. Polat and his team in Turkey in 2015 administered quality of life and depression questionnaires to 30 laryngectomy patients before receiving a voice prosthesis and then 3 months after receiving one. Quality of life scores increased from an average score of 95 to 105 after receiving a VP. Self-esteem, depression and anxiety scores also improved after VP insertion. If you want to read any more on quality of life, following surgical voice restoration. I've just popped down 3 more references for you to look at there. So let's now have a think about what successful tracheoesophageal speech looks like. Successful tracheoesophageal voice is dependent on several factors. Firstly, selecting the right patient for this type of voice rehabilitation is successful. I'm sure most of us have experience of tracheoesophageal voice failure when patients have been unsuitable for a voice prosthesis. For example, those with a cognitive impairment or poor hand-eye coordination, or perhaps poor spousal or family support. Secondly, the timing of that voice prosthesis placement and surgical technique can have a substantial influence on DEP success, with clinical evidence demonstrating that primary punctures and primary voice prosthesis placement have the highest success rate. Research shows that in general, the first indwelling VP, the one that's placed at the time of surgery, often lasts longer than average. And I would say that was my clinical experience as well. Patients who receive a VP at the time of laryngectomy don't have to go back to theatre for an additional procedure. They can achieve early voice with the positive psychological impact that brings. And they're equal or greater likelihood of successful voice with a primary puncture, as shown by the Boscolo-Rizzo paper in 2007. In terms of surgical kit, use of a specialised puncture kit can create a round tracheoesophageal tract, as opposed to a scalpel puncture, which can result in irregularly shaped tract and potential future peripheral leak. With primary placement of the voice prosthesis, you're avoiding needing to use a catheter or a nasogastric tube through the puncture, which can avoid unnecessary irritation, enlargement, edema, angulation of the puncture, all those things that make putting a subsequent VP in quite difficult. And then, of course, successful tracheoesophageal speech cannot take place without a pharyngoesophageal segment, which is capable of vibrating adequately to achieve successful voice. And then finally, the diameter of the voice prosthesis is inserted, and the airflow characteristics of that VP cannot be underestimated, with ease of airflow and the amount of air flowing through the VP as essential for PE segment vibration. So let's now turn our attention to some of the considerations when selecting a particular voice prosthesis for a patient. As we know, when a patient uses a voice prosthesis, pulmonary air is transported through the prosthesis, causing the mucosa of the neoglottis to vibrate. And that neoglottis is formed by the musculature and the mucosa of the esophagus, although the exact location of the vibration will vary from person to person in anatomy, form and structure. And any of us that have carried out a FEES on a laryngectomy patient will be aware of those differences. As we've also already mentioned, the success rate of tracheoesophageal voice is between 80 and 90%, and it's the gold standard of alaryngeal speech. So let's now take a look at this video clip showing pharyngoesophageal segment vibration. Thanks to the Netherlands Cancer Institute for sharing this video with us. It's basically filmed through a nasendoscope. There you can see the PE segment vibrating. I actually find it amazing to watch this and see how similar that vibration of the PE segment is to vocal cord vibration. Brilliant video. Okay, so when considering which voice prosthesis to use, it may be useful to consider how much a voice prosthesis will allow the patient to achieve an easy and effortless voice. Will they be able to achieve adequate volume of voice with the ability to be heard and understood by the listener? Need to be able to achieve social acceptance. and we need to give the patients the choice of voice prosthesis to achieve successful voice and self-acceptance. We need to think about the ability of the patient to maintain the prosthesis independently without risk of accidentally knocking it out or damaging it whilst cleaning. We also always find that patients are very keen on hands-free speech, so we need to think about the ability of that voice prosthesis to facilitate hands-free speaking for that patient. So as a clinician, which areas might we consider when we're choosing a voice prosthesis? You might be thinking about how quick and easy it is to insert that VP. You might be thinking about the cost. Have you got one in your cupboard? We might also be more familiar with a certain type of VP, especially if that is the voice prosthesis we were initially trained on. We need to think about if there might be an element of implicit automatic bias in our clinical decision making. We need to regularly challenge our practice against the current clinical evidence. Is our thought process non-evidence based and habitual? Is it what we have always done? Is what we think we know actually correct? Is it current? Then we think about the patient perspective, and we may see some different criteria. Patients may be, and often are, most concerned about the ease of voicing, and this may have a diameter implication from the outset. We know that patients also want a VP that's easy to clean and care for, with good visibility. Patients also rate VP device life as important, with as few trips to hospital for VP changes as possible. And lastly, as already mentioned, patients rate being able to speak hands-free as high on their agenda. So it seems that we should consider the clinician's perspective, but also the patient's perspective to maximise their outcomes and quality of life with a voice prosthesis. I'm going to go through a chart now, which is a flow chart, which summarises considerations when selecting a voice prosthesis. It can be a useful tool for clinicians. I'm happy to make it available to anyone who would like it. So we're thinking of that patient that had their first voice prosthesis placed in theatre, which was a Provox Vega, but they've come to clinic needing to have it changed. What kind of voice prosthesis are you going to give that patient for their first change? If it's a standard or just a scheduled VP replacement, you're probably going to swap it for another Vega. But if the patient shows that they want to start self-changing, you might change them to a Provox NID. It might be they've come to you with early leakage through the VP, so central leakage occurring frequently. This might be because of a blockage, so it's about teaching the patient to make sure they're cleaning it properly with the Provox brush and the Provox flush. Early central leak may be due to biofilm, so candida building up on the voice prosthesis, and you may therefore consider trialling the Provox ActiValve with a light magnet. Or you might find that the voice prosthesis is opening under pressure during breathing and swallowing, which is causing it to leak. And then you might want to think about trying the Provox ActiValve with the strong or the extra strong magnet. And then another scenario you might come up against is peripheral leak, so leakage around the voice prosthesis. It's really important when that happens to think about why the patient has got peripheral leak. It might be that their voice prosthesis is just too long, so it's prisoning in and out of the tract and causing leakage around. In that situation, you would want to downsize and make sure the patient has the correct VP length. If that's not the cause, if the fit is really nice, but you're still getting that peripheral leak, you need to think about what the health causes might be for that. For example, diabetes, reflux, some recent weight loss. Also worth checking in on recurrence if you're seeing that type of peripheral leak. But we usually use a troubleshooting valve to manage peripheral leak in these situations. So you might want to try the Provox extra flange, where you're just adding the extra flange with your Provox Vega in situ. You might want to try the Provox Extra Seal, which is the voice prosthesis with the 2 esophageal flanges. Or you might want to have a combination of both. You might find that with a more significant peripheral leak that you need to use the Provox Extra Seal on the esophageal side and then the extra flange on the tracheal side. So just a quick overview on voice prosthesis selection. Firstly, you need to decide whether the patient's VP will be indwelling or non-indwelling. And this is largely determined by the patient's wishes and whether they want to be able to self-change. You then have to consider which diameter that first voice prosthesis is going to be. Are we going to choose the smallest diameter available, something in the middle, or the largest diameter? It's important to find out what length that VP needs to be, as well as bear in mind the cost. In terms of maintenance, how easy and problem-free is that voice prosthesis to insert? How easy is it for the patient to clean or their carer to clean? And is there an option to plug it if they've got central leak over a weekend or Christmas bank holiday, something like that? And then moving on to think about voice prosthesis performance. What are the airflow characteristics of that VP? Ideally, we want air to flow through the voice prosthesis with ease, thus creating effortless voicing for the patient, free of strain. You also need to think about the perceptual characteristics of the voice offered by the VPs, so volume, pitch, and fluency. Device life is, of course, another important aspect of tracheoesophageal voice rehabilitation, as are potential complications that having a VP in general may result in. And then finally, the selection of a VP should encompass the potential to use hands-free speech, which we know is the ultimate goal for many patients. So let's have a look now at those types of Provox voice prostheses in more detail. So the Vega is clinician placed. It's an indwelling voice prosthesis. It's clinician placed. It can be placed intraoperatively or changed in clinic, and it's cleaned in situ with the Provox brush and flush. So the Provox Vega is available in 3 diameters, 17, 20 and 22.5 French, and in various lengths depending on the length of the tract. There are also problem-solving VPs, which I just mentioned, so the Extra Seal for peripheral leakage, which has its additional large esophageal flange, and the Activalve for central leak, which is candida resistant and contains magnets of varying strength to deal with unintentional flap openings. Then in terms of a indwelling option, so one for a patient that might want to change their own valve, we've got the NID, and the NID is available in a 17 and a 20 French. There are 3 possible methods of inserting the Vega, depending on a clinician's. So you've got the system insertion for straightforward, easily accessible punctures. You've got tube insertion for more difficult to reach or those angled punctures. And then you've got the gel cap insertion, where the esophageal flange can be quickly and easily inserted into a gel cap if you use a folding tool and the twist lock. I want to move on now to think more about the diameter of voice prosthesis and how you go about selecting that diameter for your patient. Is it something you actually consider every time you place an initial VP, or do you always start with the same diameter? Now, I'm aware we have clinicians in attendance from across the globe, and clinical practice does differ. Excuse me. For example, I am aware that in Europe, only the 22.5 French VP is used. So our European audience may be wondering why I'm even talking about diameter. But in the UK, and I know this is similar in the States and Australia, there is varied clinical practice with all 3 diameters of VP being used. So the 16 or 17 French, the 20 French, and the 22.5 French. But if we remember the patient-led goal of that ease of voicing, this can be achieved by adequate airflow through the VP and the vibratory capability of the P segment. So in order for that patient to have easy, effortless voice, we need enough airflow through the voice prosthesis. So on the right here, we can see the difference in airflow through the VP of a 22.5 Vega, so our widest diameter voice prosthesis, and a smaller inner diameter VP. The illustration on the left demonstrates what a larger diameter, in this case 22.5 French Vega, voice prosthesis can achieve, namely increased airflow through the VP, resulting in improved vibratory capacity of the PE segment, reduced speaking effort for the patient, increased volume, and improved voice quality. Reduced speaking effort can ultimately result in reduced intratracheal back pressure on the adhesive, meaning that you get a better and longer seal of adhesive, so you're not going to blow it off several times during the day due to the effort of voicing. And this can be particularly important when you're trying to achieve hands-free speaking. So larger diameter and increased airflow equals better vibratory capacity and decreased effort to speak. And that has been shown by Hilger et al. And a few other references at the bottom of that slide. So the larger Vega opening area can be seen in this illustration, and it's the result of a larger inner diameter, whilst the outer diameter remains the same. So it remains a 20, a 17, a 20, or a 22.5 French, but with a bigger inner diameter, as well as an effective flap opening. So in these diagrams, we can see the difference between a 20 French Vega inner diameter and a 20 French VP from another manufacturer. So we've talked about the clinician and the patient's perspective, and let's hear what the patient perspective is. So Alan's just going to talk to you now on this video about his experience of an increased diameter voice prosthesis.
Hello, my name's Alan. I'm a laryngectomy. I've had a laryngectomy for 6 years. I'm also a clinical nurse specialist for head and neck cancer patients, and I support patients with laryngectomies throughout the southwest England. Up to recently, I had a 20 French Provox Vega in situ. Recently, I went from a 20 French to a 22.5 French, and I cannot believe how my voice has improved. I have more intonation in my voice, and my voice is louder. And most importantly, I need the least amount of pressure to speak. And just to show you how much pressure I don't need, I'll show you this. So my Larry button just sticks into my stoma with no fastenings. And now I can voice free hands with no pressure needed to voice. The amount of pressure from a 22.5 French is so little that to me, it's transformed my life and improved it greatly. Thank you.
So great to hear the patient's perspective on that wider diameter voice prosthesis. So I'm now going to hand over to Richard, one of our R&D engineers here at Atos Medical, who's going to explain more about why and how Vega was created to achieve optimal voice for patients.
My name is Richard Falkenberg. I hold a position as Innovation and Research Director. I have been with the company for 20 plus years, and my background is mechanical engineering. I was involved in the development of the Vega and was asked if I could give you some insight in the development of the Vega. So here we go. If we start with the features and benefits or the claims, Provox Vega is designed for high voice quality. At the same time, a low speaking effort. It shall be easy to clean and maintain. It shall also be a robust voice prosthesis. It shall have a robust design. Each and every Vega leaving the production site is tested to be leak-proof. Opening pressure is tested on each to make sure to be within specification. This is done to make sure that the user gets the same user experience every time. The Vega should be easy to place. It is designed for easy insertion. Use whatever method you prefer, capsule, tube insertion, system insertion, or combine it with an overshooting. The thinking is that we cannot teach one way of doing the insertion. We shall adjust to the clinician's preference. Next slide, please. If we look at the design and the features, the angle flap valve design gives an increased possible opening area, and at the same time a pre-tension of the valve flap towards the sealing surface of the ring. Pre-tension makes sure we have a good closing of the valve, even if some biofilm is present. Inner diameter. The inner diameter shall be as large as possible. A big opening area is important to have nice flow characteristics. However, there is a limitation, as you need a certain material thickness to be able to produce the components of the voice prosthesis. Clearance. The flap clearance is important for loud voicing. When talking with loud or strong voice, our users are forcing a large amount of air through the voice prosthesis. If the valve flap is hindered to fully open, you will have more restriction and the user has to push harder. Valve flap design. The design of the valve flap is made so it's not possible to retract it into the inner lumen of the blue ring while brushing or swallowing. If you have a more flat design of the valve flap, this might be possible. An inverted flap causes massive leakage when drinking. The ring. The blue ring is rigid, and this gives a robust design, non-sensitive to puncture contractions or being affected by strong coughs. But another thing, it's not only about the design, because you have to be able to actually manufacturing these components as well. So as a designer, you have to use your manufacturing processes into your favor, so to say. Components included in the Vega are small and made in advanced materials, which require special know-how to be able to produce them. Additionally, the required tolerances to have a stable process and a product within specifications are high. And we at Atos, we have that know-how in-house, and that's a must. Next slide, please. Voicing of the Vega voicing. When trying to judge a VP, it is of great help to understand this graph. The y-axis describes the pressure needed, or you can say the y-axis describes the effort needed for the user to create flow. More flow, louder voice, and higher effort. The x-axis represents the flow. If we look at the Vega 22.5 at 9 liters per minute, we get a value of 12. For now, we can skip the units. Just remember 12. Effort needed is 12. If we look at the Vega 17 French and compare, we get the value 19 in effort needed. So this means that there is a difference of 7 units between the 17 French Vega and the 22.5, or 58%. So 58% more effort to create the same amount of flow compared to Vega 22.5. The corresponding value for dual valve is 36, so it's actually 3 times the effort for the Vega 22.5. And I should mention that this graph is it's made by Peter Kress and Hochschule Eschelingen in Germany. So it's not a test or curves performed or manufactured or done by Atos, just for your information. So the aim when developing Vega was to create a voice prosthesis with lowest possible flow resistance in the speaking range, and at the same time have a distinct opening pressure to secure a leak-tight valve when not speaking. And this is actually tricky, but Atos, we are good at it. So, but remember this, a flat curve is better than a steep one. Next slide, please. If we look at the inner diameter, or the measurements of the voice prosthesis, but I will discuss or talk about inner diameter. So the table shows that a 16 French Bloomsinger is 3.09 millimeter inner diameter. The value for 17 French Vega is 3.45, so it's a bit larger. 20 French Bloomsinger is 3.36. Vega 20 French is 4.17. So that means that the Vega 20 French has an opening area which is 32% larger than a Bloomsinger Classic 20 French. Yeah, I think that's it.
Thanks very much, Richard. So extremely interesting information shared there. And I find it so interesting to think about a voice prosthesis from that research and development perspective. Okay, so next up, we're going to think about some of the clinical evidence and what it says about the Vega voice prosthesis. So in terms of clinical evidence for voice prosthesis, the areas of consideration are usually perceptual characteristics of the valve, the device life and patient perceptions, airflow characteristics, and it'd be great if some future clinical evidence could also consider tissue problems. This is something we see a lot clinically, especially now with the rise of salvage laryngectomy. So thinking first about perceptual characteristics, Elizabeth Ward and her team in Australia carried out a randomized control crossover trial in 2011 to evaluate both clinician and patient perceptions of the voice with Provox Vega and the Blom-Singer Classic VPs. So 31 patients were involved in the study. And before the trial, patients used a combination of a Blom-Singer indwelling Classic and an Advantage and a non-indwelling Provox NIDS and Blom-Singer low pressure VPs. And these were all in combination of 16, 17 and 20 French. The patients that took part were randomly assigned a Provox Vega or a Blom-Singer Classic over a 3-week period with each VP. So both clinicians and patients rated the voice outcomes of the Vega as superior to the Blom-Singer Classic. 72% reported a better overall voice quality. 52% of patients reported less speaking effort required with the Vega. Clinicians who rated the voice sample perceived Vega voices to be significantly less strained, easier to understand, and they felt they were better overall voice samples. In terms of VP device life, Kress et al. In Germany in 2014 compared the device life of 749 VPs in 102 patients. So the standard VPs used were Provox 2, Provox Vega, and the Blom-Singer Classic. The clinical algorithm involved placing one of the standard VPs, and if the device life was less than 6 weeks, a Blom dual valve was placed. And if the device life with dual valve was less than 40 days 3 times, then the Provox active valve strong was placed, and then that was subsequently removed after 1 year if it was still functioning. And we can see from the results table on the right that the average and median device lives. The lowest device life was the Blomsinger Classic with a mean of 86 days. Vega was 107 days. The Provox 2 was at 98 days. The dual valve was 104, and the active valve came in at 298 days. So if you're thinking about median device life, there is actually a breadth of literature out there, and this table lists several studies carried out on VP device life between 2003 and 2018. And we can observe the relatively long device life of Vega in several of these studies compared to Provox 2 and the Blomsinger Classic, as well as the mean values for the active valve, which come in at an impressive 291 days and 161 days. Ellie Hancock and her team in Australia in 2012 compared patient perceptions of the Provox Vega and the Blomsinger Classic with respect to insertion, cleaning and care, and voice-related functions. And then a secondary aim of the study was to determine overall patient preference and determine which factors might influence a patient's preference. So 31 patients took part in the study. Prior to the investigation, 21 patients used the Blomsinger Classic or Advantage VPs, and 10 used the Provox NIDS or the Blomsinger low pressure VPs. And this was again a variety of 16, 17, and 20 French diameters. When we look at the results of the study, the majority of patients preferred Vega over Blom in comparable diameters. 72% of patients reported that overall speech and voice quality was significantly better with Vega. There was significantly less effort needed to speak with Vega and a significant overall preference for Vega. There was no significant difference found for insertion method of the two VPs. And factors that contributed to that overall patient preference were voice quality and volume, cleaning and maintenance, voicing effort, comfort and fit of the VP, and the insertion process. So I'd now like to turn our attention to VP diameter in a bit more detail. And a lot of the resistance to the wider diameter valves in the UK have been around whether it results in an increased risk of tracheoesophageal puncture enlargement. So is there an increased risk of peripheral leak with a bigger diameter valve? Now, several clinical studies have been carried out to examine the risk factors that are associated with an enlarged puncture. And Kate Hutchison, very helpfully, in 2011, carried out a systematic review and found no significant difference in the risk of enlargement of the TEP based on the prosthesis diameter. Kate then went on to carry out an additional study in 2012 to examine what those risk factors might be for enlarged punctures. 194 patients were examined over a 5-year period. And it was found that the overall incidence of enlarged punctures was 18.6%. The risk factors that were associated with that peripheral leak, that enlarged puncture, were nodal mets, whether they had had nodal mets, and patients who had undergone total laryngopharyngectomies, but not diameter or the insertion method used to place the VP. Heather Starmer in 2009 also found that large prosthesis diameter did not increase the risk of prosthesis-related complications, but she did identify some potentially critical risk factors that's definitely worth bearing in mind, including radiotherapy, certain medical conditions such as diabetes or reflux, and certain medications. She also found that patients who had undergone salvage laryngectomy were at higher risk of peripheral leak, prosthesis dislodgement, and tract length changes. And I think we've all probably seen that in our clinics. So just to summarise what we've talked about so far, Tracheoesophageal speech offers superior voice quality to other methods of alaryngeal speech, with a high voice rehabilitation success rate, increased quality of life, and reduction in reports of depression. Treatment mode and puncture timing, optimal healthcare professional support, vibratory capacity of that PE segment, and airflow characteristics of the voice prosthesis should be considered to optimize success rates with tracheoesophageal speech. The Provox Vega voice prosthesis has been designed with an optimized opening area to increase airflow through the voice prosthesis and reduce speaking effort. Provox Vega 22.5 French VP requires the lowest speaking effort in comparison to other diameter voice prostheses, owing to its low airflow resistance. Evidence does not show a significant difference in the risk of enlargement of the tracheoesophageal puncture based on voice prosthesis diameter. So it's thinking about that implicit bias again. Are we always going for a narrow diameter valve because that's the way we were always taught and that's what we've always put in? If the patient wants ease of voicing, should we think about putting in a wider diameter voice prosthesis? Okay, so let's think about some patients. Let's think about a couple of patient scenarios so that you can have a little reflection on your current caseload. The first up is Janet. Now, Janet had a total laryngectomy in 2020, and she had a 17 French Vega placed at the time of surgery, and she had good voice. But as she recovered from her surgery, she decided she wanted to try freehand speech. When we put the free hands on, her voice deteriorated. She needed loads of effort to achieve voice. Her neck was bulging, and she just kept blowing her base plate. I'm sure that's something we've all seen. The neck bulging and the early blowing of the base plate, as I mentioned earlier, is due to excessive tracheal back pressure. Now, excessive tracheal pressure is essentially pressure at the level of the stoma created by air resistance. And the air resistance in our laryngectomy patients is a combination of the PE segment, but also the voice prosthesis diameter. So the first step was we tried one of those freehand supports, but she just didn't like the sensation of that taped to her chest. We then also tried using a manometer as biofeedback, so trying to keep that dial in the green zone between 25 and 40 centimetres of water. But as soon as she put the free hands back on again, she was back to neck bulging, base plate blowing off. Therefore, we decided to dilate her TEP, and she had a 20 French Vega inserted. Once she had that wider diameter valve and increased airflow, she therefore had less back pressure. Her voice was fluent, it was effortless. She actually had increased volume compared to her 17 French, and she was then able to use hands-free, which had a significant impact on her quality of life and her social life and feeling socially accepted. So what other considerations might there be, perhaps before dilating up? You could try some different things to get a better base plate seal. So you might try using silicone glue, for example, or using the stability base plate to provide its own area of resistance. You also might want to try some voicing techniques, so working on easy onset voicing and breath work. But it was just felt that those weren't going to work for Janet, and we needed to upsize, which worked for her. So next up is a chap called Bill. Now, Bill had a total laryngectomy with primary puncture, and the surgeon wanted to insert a 17 French Vega. So during his inpatient stay, he was recovering from his surgery, and we reached the point where we were able to try voicing. And the patient and we as clinicians are so gutted when they are unable to achieve that first voice. So we did a VF, which showed some approximation of the PE segment, but not full approximation. Those walls in the neoglottis weren't coming together. But when the valve was taken out, he was able to achieve quite good open track voicing. So we upsized him to a 20 French valve, and he was able to achieve good fluent voice. So why would this be? So here we are seeing another case related to that airflow and resistance. I've said several times now that when there is greater airflow and less resistance, you get better voice. And that's because you get better approximation of those neopharyngeal walls. This is reminiscent of voice therapy when we're working on increased breath to power the voice. But this increased breath needs to fit through the voice prosthesis. In my clinical practice, I would certainly find this situation happened more frequently in those patients that were having a salvage laryngectomy. If you imagine that as a consequence of their radiotherapy, those tracheoesophageal walls have become stiffened as a result, and they're resistant to vibration. And a wider diameter VP is therefore needed to allow greater airflow and improved voice. So that is it from me. There's a couple of pages of references here for you, which include all of the clinical evidence that we've drawn on today. And I'm now going to hand back to Kelly for a live Q&A session. Thanks very much.
Okay. Thanks to Claire and Richard for their really interesting presentation. We're just working out how to switch the camera on. We'll now open up the discussion. We've received a lot of questions ahead of time, so I'm going to kick off with a few questions. If you'd like to post any questions, please put them in the Q&A. I'm going to start off with a question for Richard. The Vega has a rigid barrel to resist track pressures and movement and for optimized patency. Does this increase the risk of pressure to the tract or enlargement of the tract?
Yeah, well, first of all, I'm a mechanical engineer as a background. Of course, I've been working with this for almost 25 years now, voice prostheses and HMEs and adhesives for laryngectomies. But with that said, I'm not a clinician. But if you look at the voice prosthesis, a Vega voice prosthesis or any Provox voice prosthesis, it's true. We have a rigid ring in the center part that works as a reinforcement to make a stable valve. But on the outside, you have the silicone rubber, which is in contact with the tissue. So I would say no, because the silicone is gentle and it's well proven to be a very good material to have against the tissue.
Okay, thank you. Really interesting. Good to have your insight. Okay, one for you, Claire. Are there any contraindications to or risks to the tissue with increasing diameter size?
Thanks, Kelly. As I mentioned in my presentation, no, an increase in diameter size doesn't have an impact on the tissue, so the puncture site. I do think that has been a perception in the UK, certainly. But according to the clinical evidence, no, an increase in diameter size doesn't mean you're more likely to get peripheral leak.
Okay, thank you. And following on from that, how do you manage a size 22.5 French puncture that is peripherally leaking if there's no larger voice prosthesis to upsize to?
Well, in my practice, and I certainly think this reflects general practice in the UK, if you've got a peripheral leak, I wouldn't try to solve that by putting in a wider diameter valve. I think you could then run the risk of creating an ever-increasing fistula. Whenever it comes to peripheral leak, whatever diameter your voice prosthesis is, it's really important to establish why the peripheral leak is there. So, for example, we heard from Kate Hutchison's research that we're more likely to get a peripheral leak if the patient has had radiotherapy, reflux, diabetes. that sort of thing, also need to look out for recurrence. But once you've started to investigate why a patient has peripheral leak, I would always choose a troubleshooting valve to solve that with. So you might use the extra flange or the extra seal to sort out the peripheral leak while you tackle the root of the problem.
Okay, thank you. That's really helpful. Okay, Richard, what's the best diameter to achieve hands-free speech?
Yeah.
In your opinion?
Yeah, in my opinion. Well, we know that speech is created in the range from maybe 7 to 11 liters per minute. So that's the amount of flow that is needed to create a good voice, of course dependent on your PA segment. So if you have a small diameter voice prosthesis, to create the same amount of flow as if you had a large diameter, you need to pressure, you need to force, you have to create more pressure with your lungs in order to create the same flow. And that, of course, causes a lot of force on your adhesive, which your free hands is attached to.
Mm-hmm. Makes sense. Yeah, no, that makes
so
sense.
if you have a larger diameter voice prosthesis and your PA segment is allowing to create a good flow, of course it's better with a large voice prosthesis, as a large inner diameter of the voice prosthesis.
More likely to have greater success.
Yeah.
Thank you.
Just a comment, maybe. I don't know if I should say this, but we are talking, all this session is about a large diameter. Mm-hmm. And of course, that's the main thing to create a good flow. But there are other things to the voice prosthesis, where the valve is placed, how long is the hood, the design of the angle. So there are other things that also are important to create a good flow. But the inner diameter is, of course, the main thing.
Yeah. Okay, makes sense. Thank you. Okay, Claire, is it okay to upsize a tract from a 17 to a 20 or a 22 French? Do you have a protocol for how to go about this?
I thought, Kelly, it might be helpful to reflect a little bit on my clinical practice, and this question kind of will bring it in. So I was trained on a smaller diameter voice prosthesis regime, so I automatically put a 16 or 17 French VP into all of my patients. And then in more recent years, especially with the increased rate of salvage laryngectomy, I was finding that my patients weren't getting good enough voice, and so I was having to upsize them in outpatient clinic to a 20 French. And I didn't have a protocol. I'm not aware that there is a protocol out there. It was done in the clinic. Patients were warned that it may take some time, and I would use a dilator to stretch them up. Sometimes that happened very quickly, and you'd be able to put the upsized VP in within half an hour. Sometimes you had to stick them back out in the waiting room for a couple of hours. Sometimes you had to send them home with the dilator in. And I was actually starting to find, I think because that tissue was so solid from the radiotherapy, that it was taking me longer and longer to upsize a patient. And that's when I reflected on what we puncture patients with initially, and we moved on to puncturing all of the patients with the 20 French, and that saved me actually a lot of hassle in clinic. They got better voices straight away, especially if they'd had previous radiotherapy, and it meant we didn't have to go through that lengthy process of trying to stretch them up in an outpatient clinic.
Okay, thank you for sharing. Okay, we're coming close to the end. One more question, which ties into a live question for Richard. Are there any plans to modify the Vega for troubleshooting issues?
Yeah, of course. We are always trying to solve problems. Yeah, the short answer is yes, of course, but I can't tell you so much about it.
Okay, so things to look forward to possibly.
But yeah, of course. What I can say is that we are really trying to create something, or a voice prosthesis that is more predictable.
Okay.
That is a lead star, so to say. Create something that is more predictable. Yeah.
And that would be great. Thank you. Okay, I'm really sorry I'm going to have to draw the question session to an end. We've run out of time, but I would really like to thank everyone for joining our webinar today, and particularly to Claire and to Richard for their presentations and discussion. It was really interesting, and we could go on for much longer if we had the time. We will make the recording available on demand, but also our website has healthcare professional educational portal where you can access more information about products, supporting evidence, clinical tools, and upcoming educational events. We appreciate you taking your time out of the day to listen and hope you'll join us soon. When I sign off, there will be a brief survey, so please give us some feedback. Okay, take care and see you soon. Bye.